Rahim. First of all, I'd like to send my greetings to the respectful chairpersons and also to the dear audience. Also, I'd like to express my gratitude to my dear professors for giving me the honor to participate in the conference of the Rheumatology and Immunology unit of Mansoura University. Our presentation today will be image gallery about capillaroscopy and its role in rheumatology. Our gallery will include the following sections. We will talk about history of capillaroscopy, what's normal and what's abnormal. Also, we will talk about the role of capillaroscopy in differentiation of primary and secondary Raynaud's phenomena. We will talk also about scleroderma spectrum disorders, non-specific changes in other connective tissue disorders, and capillaroscopy and its role in vasculitis. We will start by brief history of capillaroscopy. Interest in capillaroscopy started when Italian physician Giovanni Rosari first noted the close relationship between conjunctival inflammation and presence of capillary loop changes with magnifying glass. Then, at the beginning of 20th century, primary and secondary Raynaud's phenomena was differentiated using vascular changes. However, the capillaroscopy was neglected for several decades until the appearance of high magnification nail-fold video capillaroscopy, which lead to more use of capillaroscopy in characterization of Raynaud's phenomena and other rheumatological condition. This image is for the first page of Raynaud's thesis published in Paris 1862. This image showing that some capillaries are abnormally altered that can be seen with naked eye without need of any magnification. However, the magnification is usually required for better visualization of the character of the capillary changes. The capillary walls are themselves not invisible. What's seen is the column of red blood cells within the capillaries. What about the instruments used for capillary examination? Here we can find the ophthalmoscope, which can be used. However, it has low magnification, about 10 times. This is an image of capillaroscopic examination using the ophthalmoscope. We have also the dermatoscope. However, it also has low magnification power. It's about also 10 times or slightly higher. Then the new high magnification video capillaroscopy, which have high magnification power, it's about from 200 to 600, is considered to be the gold standard, but it may be not available in all the centers. Here we can see the capillaroscopy, the conventional one. Here the handheld instrument, which is usually connected to software for saving images and for measuring and quantification. This is the oil which is used for better image. This image showing the difference of image obtained from dermatoscope and capillaroscope. As we can see in this image, we can find that the capillary changes may be so abnormal that can be visualized with dermatoscope. We can see here the giant capillaries and the hemorrhage, which is more visible with the high magnification power nail-fold video capillaroscopy. However, in most cases, high magnification is required. At this image, we can see that the giant capillaries are not visible for the dermatoscope. Also, the same condition with the normal capillaroscopic and non-specific changes. Now we will talk about what's normal and what's abnormal. The criteria of normal capillaroscopy, it's usually the skin should be transparent and visible, and the capillaries are clearly visible with no capillary edema. Subcapillary venous plexus may be visible in about 30% of healthy population. The capillary architecture, the capillaries should be parallel to each other. The shape of the capillary should be U-shaped. Diameter should be less than 20 micrometer. Usually there is no tortuous, dilated, giant or ramified capillaries, no angiogenesis, no hemorrhage or hemosiderin deposits, and the capillary density is usually from 9 to 13 in 1 linear millimeter. As regard there is no avascular areas, no the distance between the two loops not more than 500 micrometers. The capillary blood flow should be dynamic, no stasis or thrombosis. This is an example of normal capillaroscopy. You can note that the capillaries are clearly visible. There is no pericapillary edema. The capillaries are U-shaped. It's normal length. Also, it's normal diameter, no dilatation or giant capillaries, no abnormal shape or morphology, no hemorrhage or hemosiderin deposition. There is normal density. No, we cannot find any avascular areas. This is also examples of normal capillaroscopic image. Here you can note the subpapillary venous plexus, which is maybe also in this image, which may be a normal finding about 30% of the population. This is another example of a normal capillaroscopy, and this is subpapillary venous plexus. What's abnormal finding? We can note here that there is an increase in the diameter of the capillary. This is called giant or mega capillary. Also, we can find this is tortuous capillary, in which the afferent and efferent capillary loops intersect at more than at two or more points. Also, we can see here that there is hemorrhage, points of hemorrhage, and also hemosiderin deposition. Here we can find the ramified or capillaries and the new angiogenesis. In this image, we can find that there is here a vascular area with no vascularization, no capillaries, and this is abnormal. Also, we can find that the length of this capillary is elongated. This is called elongated capillaries. Next, we will talk about the capillaroscopy and its role in Raynaud's phenomena. As all we know that one of the most important indications for doing capillaroscopic examination is the Raynaud's phenomena. It's used for differentiation of primary Raynaud's phenomena, in which the capillaroscopic examination is entirely normal, and secondary Raynaud's phenomena. Here we can see this image, which is for normal capillaroscopic examination, in which the capillaries are U-shaped with normal density clearly visible. Here we can find that there is a lot of abnormalities. We can find this giant mega capillaries, slightly disturbed capillary architecture. We can find this hemosiderin deposition denoting hemorrhage. This is a case of a case of primary Raynaud's phenomenon, in which there is normal capillaries. The capillaries are normal in shape, U-shaped. We can find the density is more or less normal, no avascular areas. So this is a case of primary Raynaud's phenomena. These also examples of abnormalities found in secondary Raynaud's phenomena. We can find here the giant capillaries. We can find the hemorrhage. We can find here the avascular areas. Also, we can find that the capillaries are slightly hazy, which is denoting damage to the wall of the capillaries. Next, we will talk about what's called scleroderma spectrum disorders. As all we know that one of the most important indications for doing capillaroscopy is in cases of scleroderma, which it can differentiate the stage or the pattern, also can predict the internal organ involvement. As Dr. Mary said, we have what's called scleroderma pattern, which can be classified into early, active, and late scleroderma pattern. First, we will talk about early scleroderma pattern. As we can see here, that the capillary architecture is normal, it's not disturbed. We can find some giant capillaries and some hemorrhage. However, there is no evidence of ramified or giant capillaries and no major capillary loss. This is called early scleroderma pattern. Here also a case of early scleroderma pattern. We can find some giant capillaries, some hemorrhage, but preserved capillary architecture, no major capillary loss. Also, in the case of active scleroderma pattern, we can, in case of active scleroderma pattern, we can find that the giant capillaries become more frequent, and also the hemorrhage. There is begin to be some capillary loss and few or absent ramified capillaries. This is also a case of active scleroderma pattern. We can find the giant capillaries and the hemorrhage. This also image for the giant capillaries or mega capillaries. We can find here the hemorrhage. As regards scleroderma pattern, the major evidence is the desertification or a major capillary loss, and we will find the new angiogenesis or ramified capillaries. Here also there is desertification, loss of capillaries. We can find here the new angiogenesis or new vascularization. This is a new vascularization image for the new vascularization and angiogenesis. It's very important to know that the hallmark of scleroderma pattern is the presence of the megacapillary, as we can find in this image. This image showing the early scleroderma pattern. As we can see, the preserved capillary architecture, some dilated capillaries. Here we have the active with giant capillaries, some capillary loss, and we have here the hemorrhage, and then we have major capillary loss with the ramified capillaries. Also the same, this is normal capillaroscopy. This is early scleroderma pattern with preserved architecture. Here, the active scleroderma pattern with the giant capillaries and with the hemorrhage. Here you can find the late scleroderma pattern, in which there is loss of capillaries and there is new angiogenesis. The same we have here, early scleroderma pattern. This is active scleroderma pattern, and this is late scleroderma pattern with capillary loss and the new angiogenesis. As Dr. Mary said, that the capillaroscopic finding can predict the development of skin ulceration. We have what's called skin ulceration risk index, which depend on the number of which depend on its score, depend on the diameter of the biggest giant loop, the number of giant loops, and also the number of all loops in the field. This score, when calculated, it predicts the development of skin ulcers in scleroderma patients. This table summarizes the pattern in different connective tissue disorders. What about what's scleroderma spectrum disorder? These are heterogeneous group of connective tissue diseases linked to systemic sclerosis and exhibiting characteristic capillaroscopic abnormalities. These include the giant capillaries, loss of capillaries with avascular areas, ramified capillaries, pathological new angiogenesis, severe derangement of the capillary architecture. These changes are very similar or typical for scleroderma pattern. However, these changes, when present, it's called scleroderma spectrum disorder, and it's present in a number of disorders to a different extent. These disorders, besides the scleroderma, we have mixed connective tissue disease, dermatomyositis, and also primary biliary cirrhosis. This is a capillaroscopic examination in a patient with a mixed connective tissue disease. In patients with mixed connective tissue disease, the capillary involvement vary greatly. It may be normal image, may show non-specific abnormalities or severe microangiopathic changes, which is very similar to a scleroderma pattern. However, it was found that there is a difference between scleroderma and mixed connective tissue disease, that there is less giant capillaries in mixed connective tissue disease compared to scleroderma. Also, there is a higher absolute number of total capillaries compared to scleroderma. In this image, we can note that there is some convoluted capillaries. These capillaries are so convoluted, and this is called pseudoglomerulus appearance, which is characteristic for mixed connective tissue disease. As regards dermatomyositis, dermatomyositis has a well-defined pattern, which is include two findings. We can find enlargement of the capillary loops, loss of capillaries, disorganization of normal capillary distribution, budding or bushy capillary, as we can see in this image. This is called bushy capillary. This one. Twisting of the twisted enlarged capillaries, also the capillary hemorrhage. This pattern is called scleroderma-like pattern. We can see here the twisting of the capillaries. Here we can find the pushy, what's called pushy capillaries. As regards primary biliary cirrhosis, all of us know that there is a coincidence between primary biliary cirrhosis and systemic sclerosis. So capillaroscopic finding of scleroderma pattern in patients with primary biliary cirrhosis predict that the patient may develop systemic sclerosis or having systemic sclerosis. And also this correlate with the presence of interstitial lung disease. What about the non-specific changes, which can present with other disorders? With other connective tissue disorders, we can find what's called non-specific changes. Other connective tissue disorders like the systemic lupus, Drager syndrome, we have unique capillary patterns. These non-specific capillary abnormalities, including lower capillary density, a change in the capillary dimension, either elongation or widening, prominence of the subpapillary venous plexus, hemorrhage, and abnormal shapes like the pushy or bizarre capillaries. However, these abnormalities are not predictive of any definite condition. Also, unfortunately, these abnormalities may be found in patients with primary Raynaud's phenomena, and this will be very difficult to discriminate primary from secondary Raynaud's, which will progress to one of the connective tissue disorders. However, it's a general rule that when you find the abnormality which is isolated or uncommon, it may represent a variation of normal. However, numerous or several abnormalities in one individual, this indicates underlying connective tissue disease. These are examples of the non-specific changes. Here you can find that there is abnormal density, there is low density in the capillaries. Here you can find abnormal dimensions. Some of the capillaries are slightly dilated. Also here we can see abnormal shape of the capillaries, slightly twisted. Here we can see the presence of hemorrhage of the capillaries, one of the non-specific changes. Now we will talk about the changes which occur in some connective tissue diseases. Capillaroscopy, and we will start with systemic lupus. Capillaroscopy of systemic lupus may be normal. However, it may show non-specific changes, like the elongated capillaries, as we can see in this image. We can see tortuous, corkscrew, pushy capillaries, bizarre shape, and also the venereal visibility. This image showing the elongated capillaries and also the visible subpapillary venous plexus. And this image, we can see here the convoluted capillary, the bizarre shaped capillary. Also, in systemic lupus, it was found that the near-field capillaroscopic changes correlate with the disease activity, severity, attacks of Raynaud's phenomena and gangrene. Also, it correlates with the positivity of anti-U1 or NP. As regards rheumatoid arthritis, we can see that there is increased the capillary tortuosity, there is increased visibility of subpapillary venous plexus, and these capillaroscopic changes are more with patients with extra-articular manifestations. As regards antiphospholipid antibody syndrome, it was found that capillary diameters was found to be significantly smaller, which is different from what's found in systemic sclerosis. Also, there is symmetric microhemorrhage, as we can see in this image. However, there is no difference in the capillary density or the blood flow velocity. Capillaroscopic changes in antiphospholipid antibody syndrome was found to be correlated with the positivity of anticardiolipin, IgG, and IgM. Also, thrombotic manifestations correlate with microcirculatory changes. Finally, we will talk about the vasculitis and the role of capillaroscopy in vasculitis. The most widely reported findings in vasculitis are the microhemorrhage, vascular areas, which are not specific enough. So more specific pattern for active vasculitis is required. Here we can find that what's called pericapillary stippling. These are small pigmented spots which can be seen at the apical segment, over the apical segment of the capillaroscopy. It was found about 30% of patients. It represents a leakage of blood cells from the capillary loops. It's found in about 30% of patients with vasculitis. Also, what's called rolling, in which there is disrupted flow of red blood cells that can be seen as there is some rolling, there is some disrupted blood flow in the capillaries. It was found in about 75% of patients with active vasculitis compared to only 12% in patients in healthy controls. As regards rheumatoid vasculitis, this is normal capillaroscopic image. However, here we can find that each dermal papilla contains more than one capillary. Also, there is some convoluted and some twisted capillaries. This is characteristic for rheumatoid, found to be more in cases with rheumatoid vasculitis. Also, in Behçet's disease, it was found that there is enlarged capillaries. Avascular areas were more found in patients with Behçet disease compared with the healthy controls. Finally, I'd like to say that the abnormalities in the capillary morphology can be observed long before the onset of clinical symptoms in systemic disease, in which vascular damage is one of the pathogenic factors, like systemic sclerosis and many also immune connective tissue disorders. Patients already diagnosed with systemic disease, damage to the capillary may reflect the involvement of internal organs. For this reason, capillaroscopic examination is very important. And thank you.